All right, guys, I wanted to go over some education with you about UTIs and the difference between what is a UTI and what isn't a UTI that's classified here. And I figured this was the best way to reach out to you guys. I know that everyone has trouble getting to the meetings and things like that every month, so this is just a good way for us to just kind of group together and I can really get that information out to every single one of you. The objectives that I'm going to go over today is defining symptomatic UTI versus asymptomatic bacteruria, reviewing UTI assessment criteria, and identifying UTI risk factors and prevention strategies. So why should we focus on UTIs in the nursing home? UTIs are the most frequently reported infections in long-term care, and they are a significant cause for rehospitalization and sepsis. Monitoring of symptomatic UTIs help identify trends in these infections and provide data to improve antibiotic use in our facility. So about 30 to 60% of antibiotics in skilled nursing facilities are for suspected UTIs, and about 40 to 75% of those antibiotics used may be unnecessary or inappropriate. So I'm going to do a little definition here. I know a lot of you nurses, this is drilled into your brain, especially during nursing school, what a urinary tract infection is. So I'm just going to kind of go over it briefly. The definition is it's an infection that involves any of the organs or structures of the urinary tract, including the kidneys, ureters, bladder, and urethra. Most commonly, it is a bladder infection. So some risk factors of someone who might have a UTI would be their age that you need to consider. So their age, especially over 80. If they're a female, and that's usually because of their pericare, poor pericare technique. If they have a neurogenic bladder, if they have reduced mobility, incontinence, a previous history of a UTI, prostate enlargement, kidney stones, or catheters. So diagnosing UTIs in the nursing home. So this is where we kind of need to figure out if this is a correct criteria to get a UA for a UTI or if it's not. So some important definitions that I'm going to be talking about here is bacteruria, and that is bacteria in the urine, and resident can have a positive urine culture from that. Asymptomatic bacteruria in the absence of genitourinary signs or symptoms. And then you have symptomatic UTI, bacteria in the presence of genitourinary symptoms. Those symptoms can include the fever, dysuria, the suprapubic pain or tenderness, frequency or urgency. So we really need to understand the difference between the asymptomatic bacteruria and the symptomatic UTI. The asymptomatic bacteruria is most commonly found in all elderly patients. And that's just when you have natural bacteria that just sits in your urine. A symptomatic UTI is when they are actively having a urinary tract infection. So if you were to get a UA on every single resident in this building, about 80% of them will come back with bacteria in their urine. And that's because they have asymptomatic bacteruria. Does that mean they have a UTI? No. So we really want to go based off the fact of if they're symptomatic or not. So detecting an infection. This can be more difficult in the elderly. They may have subtle symptoms. They may not display classic symptoms due to inadequate immune response. And comorbidities may impair residents' ability to verbalize or recognize those symptoms. The things that we need to investigate are new or increased confusion, reduced food intake, so they're not eating as much, if they're having more frequent falls, or if they're having new or worsening incontinence. This does not mean that they're just incontinent and that's their norm. This means that this is something new that's happening that's out of their norm. So if you were a nurse before 1980 or you were born before 1980, you were probably taught in nursing school that if an elderly patient experiences a change in mental status, that you should immediately suspect a UTI. Many of us are so efficient that we had the urine sample labeled and ready to send to lab, and we had already checked the e-kit supply to make sure we have that antibiotic already readily available for them to use. Well, guys, times have changed, and now we know that a change in mental status is often in no way related to a UTI and should not be the only criteria for suspecting a urinary tract infection. And it's kind of true that many residents will have that funky, junky urine where it's constantly cloudy and foul smelling, but that is still not enough to meet the criteria for a true UTI. So this right here is the McGreer's criteria for infection report form for urinary tract infections. This is something that I need you guys to make sure that you are doing every single time before you are getting a UA on these residents, okay? Now, there's two different categories here. There is a category for residents without an indwelling catheter, and then there's a category for residents with an indwelling catheter. Now, when you look at these categories, you're going to have, so this box with the resident without indwelling catheter, it says that has to have 2 or more symptoms for it to qualify to meet the criteria. So there's your fever, and it has to be above 100 degrees or 2.4 degrees above baseline for them. Dysuria, urgency, frequency, suprapubic pain, gross hematuria, flank pain, urinary incontinence that is new or worsening, and then your shaking chills. So we really need to make sure that we are looking at that before we are getting that UA. And then your residents with an indwelling catheter, it kind of has some of the same things, except it does have the delirium new onset. So make sure you guys are really looking at that. Make sure you guys are filling that out, and make sure you guys are signing that and putting that back in your McGreer's antibiotic logbook that is posted at each station. It should be right up there at the nurse's desk. That's where you guys, if it's not there, that's where you guys need to put it, okay? So when should a UA culture and sensitivity be sent? Urine testing should be performed when a resident has localized urinary tract signs and or symptoms. Odorous or cloudy urine are not indications for urine culture or analysis. These changes alone do not represent a UTI. So even if urine odor is caused by bacteruria, this does not indicate that infection needs to be treated unless other symptoms are present. So I'm going to go back to McGreer's, make sure we are always using that UTI criteria form to determine if we are even good to go on getting that UA on that resident, even if they're having those active UTI symptoms. So why not treat it just in case? Multiple randomized clinical trials in treating asymptomatic bacteruria in long-term care residents have shown no benefit in treating it just in case. There's no difference in the number of symptomatic UTIs. There's no improvement in survival, and it doesn't even reduce the risk of sepsis. Asymptomatic bacteria treatment is known to cause increased adverse drug events, C. diff, and increased antibiotic resistant organisms. So really, it's not doing them any good at all to just give it to them just in case. So some UTI prevention. I know I have drilled that in your guys' brains so many times. Make sure we are educating. Make sure we are nurses. Make sure we're educating staff. Nurses, make sure we're educating residents. We need to go over hand hygiene for both residents and staff. I do drill that in your head as well. I say that a lot, but I do. And nurses, it's your guys' job to educate your staff to do hand hygiene on residents. Residents need to have their hands washed before and after meals, at least. Do you guys know where them hands have been? Because I don't, and I don't want to know. So let's make sure that they're washing their hands as well. Even if they're not going down there and taking care of themselves, they still need to wash their hands. Make sure that we are teaching proper peri-care technique. Make sure your staff is well adapted to doing proper peri-care technique. Make sure, nurses, that you are teaching your residents proper peri-care technique. Make sure we're telling them to wipe from front to back instead of back to front. We don't want that stuff from the back sliding its way to the front and sitting there. That's a huge UTI risk. Make sure we're offering them plenty of fluids. Every time you guys go in the room, even if it's to say hi, offer them a drink. Residents, when they get elderly, they forget. They forget that they need to hydrate themselves. So make sure you guys are doing that for them. Make sure you guys are passing your ice waters, and keeping them stocked up on that water for them so that they have it readily available. We got to do routine of toileting. So the golden rule here is 2-hour toileting. I know it's hard with some shorting staff here lately, but just make sure that your residents are nice and dry. If they have to go to the bathroom, make sure you're taking the time to take them to the bathroom. You guys always know to come get me if you need help, even if it's for a transfer or to do some peri-care. I do not mind chipping in. If you just come by and ask me. So if you guys have any questions or comments, let me know. Write something down below you've learned. Anything works. I do need you guys to be a little interactive on this webinar. So I'm going to ask a question like, why do you love working in the nursing field? Let me know. Comment that down below, and maybe I'll put your name in for a drawing, and I will announce that in 2 weeks. So let me know, guys. Thank you so much.